Welcome to Roadmap to Residency. Hello everyone, I am Abhiraz. Welcome to our Club 250 Matchmaker sessions. We will be running through a question with you guys to help you on your journey to a 250. So, histopathology of the spleen will show which of the following. 54-year-old man comes to the emergency department after an episode of bloody vomiting. He has had no fever, chills, abdominal pain, diarrhea, or constipation. The patient has a history of alcohol abuse with multiple previous hospital admissions due to alcohol withdrawal and generalized tonic-clonic seizures. He also has a history of intravenous drug abuse and is currently enrolled in a methadone maintenance program. Blood pressure is 96 upon 62 millimeter of mercury and the pressure is 102 per minute. On examination, the patient appears comfortable but develops dizziness when asked to sit up. There is no jugular venous distension. The abdomen is distended with downless to percussion at both flanks. The liver is enlarged on palpation and the tip of the spleen is also palpable. There is trace pedal edema. Lab studies show hemoglobin 9.7, mean corpuscular volume 98, leukocytes 78,000, platelets 5,000, and histopathology of the spleen also which are the following: extramedullary hematopoiesis, histiocytic proliferation, lymphoid follicle expansion, metastatic deposits, red pulp expansion. Now, please pause the video and think what is the answer. Now, we will discuss the answer here. So, this patient with a history of significant alcohol and intravenous drug abuse has evidence of alcoholic liver disease. His hematemesis, orthostatic symptoms, and normocytic anemia are likely due to the acute bleeding from the esophageal varices. Although chronic GI blood loss can cause microcytic anemia due to depletion of the iron stores and reduced hemoglobin synthesis, acute hemorrhage is usually associated with normal mean corpuscular volume. Alcoholic liver disease also causes thrombocytopenia due to decreased platelet production, increased destruction, and splenic sequestration. Fibrosis and distortion of intrahepatic vasculature in alcoholic liver disease obstructs the blood flow through the liver, leading to portal hypertension. Now, because the splenic vein is part of the portal circulation and condition that causes so any condition that causes portal hypertension can lead to splenomegaly with congestive hypersplenism. The venous congestion causes apparent expansion of the red pulp of the spleen, which is composed of blood-filled sinuses and cords lined by reticuloendothelial type cells. Now, you know that in my lectures, we don't only discuss about the question, but we also go deep into the topic. So today in this video, we will be discussing about the alcoholic liver disease. So the normal liver, the 90 to 95% of the chronic heavy alcohol users and some moderate drinkers, the liver will just go into the fatty infiltration that is called as the hepatic steatosis. Now, in these sort of populations, the 20 to 40% will go into steatohepatitis plus fibrosis. So there is fat plus hepatocellular injury and inflammation. And then in the 10 to 20% of this patient, the patient will finally progress to cirrhosis. So the 10 to 20% of the alcoholics may finally progress to cirrhosis, and they can lead to liver failure, causing jaundice, coagulopathy, and encephalopathy, the portal hypertension causing varices, ascites, spontaneous bacterial peritonitis, and a few 3 to 10% among the cirrhotic patients will lead to the hepatocellular carcinoma. So the alcoholic liver disease, the changes, what is that? So the alcoholic fatty liver, there is macrophage infiltration, Kupffer cell activation, and neutrophil infiltration. The alcoholic steatohepatitis, there is decreased neutrophil phagocytic capacity, reduced natural killer cell numbers, and compromised cytolytic activity. The impaired cytotoxic T cells decrease the T regulatory and increase the Th17 and CD57 plus T cells. The fibrosis, the depressed natural killer cytolytic activity, the macrophage infiltration and activation is there. There is activated hepatocellular cells, and there is the proliferation of myofibroblast. So The cirrhotic sort of patients, they will have a depressed natural killer cytolytic activity, and they will have a reduced B cells count. So the non-alcoholic fatty liver disease is also there. So the non-alcoholic fatty liver disease or the hepatic steatosis, the pathophysiology is the accumulation of fat in the liver. When excessive consumption is ruled out, when the patient is only taking excess amount of fatty foods, then the fat can get accumulated in the liver, and that is called as the non-alcoholic fatty liver. And the histology, you can see there is increased number of fatty vacuoles in the liver. There is non-alcoholic steatohepatitis, also called as NAS, when there is accumulation of fat in the liver with combined inflammation and cell damage. Then there is the fibrosis. So the scarring in an inflamed liver will lead to the fibrosis, and there ultimately occurs the cirrhosis, which is the latest stage of the chronic liver disease, which is marked by the nodules of the damaged liver cells surrounded by scarring. So the non-alcoholic fatty liver without NAS or fibrosis takes an average 57 years to progress to cirrhosis. Now, this is again the histology of the fatty liver, where you can see the increased vacuoles, increased fatty vacuoles in the liver. Now, let's see about the progression. So the healthy liver, and whenever there is genetic factors involved or insulin resistance, obesity, then we have the non-alcoholic fatty liver, when there is the lipid aggregation. And when there is inflammation in this liver, then that leads to non-steatohepatitis. Then there is the scar tissue formation. And ultimately, it will progress to fibrosis, and that will lead to the activated hepatic stellate cells and nodules surrounded by the scarring, which is called as the cirrhosis. Now, the cirrhotic patients, if we do a liver transplant, now they become healthy. But if we do not, then 3 to 10% of this patient can progress to the hepatocellular carcinoma. You can see the healthy liver, the fatty liver, and the cirrhotic liver. Notice the nodules that is there in the cirrhotic liver, and the yellow fat accumulation in the fatty liver. Now let's talk about the alcoholic liver disease. So there is the different types of liver disease. So number one is the fatty change, which is the most common type of alcoholic liver disease. So the reversible disorder characterized by the presence of large vacuoles of triglycerides in the cytoplasm of the hepatocytes, which is called as the steatosis. The substrates of the alcohol metabolism are used to synthesize liver triglycerides, which accumulate in the cytoplasm and push the nuclei to the periphery of the liver cells. The clinical and lab findings include the painful hepatomegaly without fever and neutrophilic leukocytosis. Alcoholic hepatitis, severe progressive inflammatory disease of the liver characterized by the fatty change, neutrophilic infiltration of the liver, and fibrosis. Epidemiology occurs in 15 to 20% of the alcoholics. Majority are middle-aged men, and the women develop the chronic hepatitis over a shorter time period than do men, and with a small amounts of alcohol, because of the decreased amounts of alcohol dehydrogenase in this sort of population. There is increased incidence of alcoholic hepatitis in Hispanic ethnicity. The pathophysiology relates to the increased reactive oxygen species as well as inflammatory cytokines. The stimulation of collagen synthesis around the central venules produce perivenular fibrosis, which is a characteristic finding. The microscopic findings include fatty change with neutrophil infiltration, and there is Mallory-Denk bodies in the cytoplasm, which represent the damaged cytokeratin intermediate filaments. The Mallory-Denk bodies are not a specific finding for alcoholic liver damage, and can be seen in other diseases like the Wilson's disease or primary biliary cirrhosis or the non-alcoholic cirrhosis, and sometimes in case of hepatocellular carcinoma too. The clinical findings include fever, painful hepatomegaly, ascites, hepatic encephalopathy, and possible progression to the alcoholic cirrhosis. The lab findings include absolute neutrophil leukocytosis, 2 times greater increase in the serum AST and ALT, increase in the serum alkaline phosphatase and gamma glutamyl transferase, thrombocytopenia, and a fasting hypoglycemia. You can see this is the fatty liver. Note the yellow appearance of the liver. And this is the alcoholic hepatitis. Hepatocytes contain the lipid droplets, that is the triglyceride and eosinophilic Mallory hyaline bodies here. So this MH represent the eosinophilic Mallory hyaline bodies, which are present in case of alcoholic hepatitis. So there may be increased anion gap or metabolic acidosis, which is caused by the lactic acidosis and beta hydroxybutyric ketoacidosis, hyperuricemia, hypertriglyceridemia, hypoalbuminemia, or hypergammaglobulinemia, increased international normalized ratio INR, macrocytic anemia, blood-based urine test for alcohol, increased urine ethyl glucuronide, and increased serum ferritin. The non-alcoholic fatty liver disease are most commonly associated with metabolic syndrome in obese patients with diabetes mellitus. Insulin resistance is the marked hallmark of the metabolic syndrome. So other risk factors include the hyperlipidemia, prolonged TPN, and bacterial overgrowth in the small bowel, and certain medications like corticosteroids and methotrexate. The fatty change occurs in the absence of alcohol intake, and it may progress to non-alcoholic steatohepatitis, as we have discussed earlier. And it may occur in children and adolescents too, and can lead to the cirrhosis of liver with concomitant portal hypertension, ascites, and liver failure. The risk of hepatocellular carcinoma, if fatty change is present for over 10 to 15 years, then there is increased risk of hepatocellular carcinoma. Thank you for watching.